Good day, everyone. Welcome. So my name is Thomas Renson. I'm a pediatric rheumatologist at Ghent University Hospital in Belgium, and it is my pleasure to co-host today's webinar on IgA vasculitis together with Dr. Sara Monti. She's a rheumatologist and vasculitis expert in Milan, Italy. So this webinar has been organized through collaboration between ERN-RITA and EUVAS, the European Vasculitis Society, and it is particularly fitting that it takes place in May, which is recognized as Vasculitis Awareness Month, an initiative dedicated to increasing awareness of this for this important group of rare diseases. So we have two exciting speakers for you. And throughout the webinar, we encourage you to submit your questions through the Q&A chat box. You may do so at any time during the presentations. We will address as many questions as possible following both talks. So it's now my great pleasure to introduce our first speaker, Dr. Augusto Vaglio. Dr. Vaglio is a nephrologist at Meyer's Children's Hospital in Florence, Italy, and his clinical and research work focuses on systemic autoimmune diseases, with particular expertise in IgA vasculitis and ANCA-associated vasculitis. So, Dr. Vaglio, thank you for being with us today, and the floor is yours.
Thank you, Thomas. Thanks very much for inviting me to give this talk together with Alexandra. It's a pleasure for me because this is a field that we are working on, and also because I'm a EUVAS member since quite a long time, and I'm always pleased to participate in EUVAS initiatives. So this talk will be divided in two parts. The first is the one that I will cover, and it will mainly be on the clinical presentation of the disease, on kidney involvement, and on pathophysiology, whereas other clinical aspects like overlapping diseases, disease triggers, and treatment of IgA vasculitis will be covered by Alexandra. So this is the outline of my presentation. So first of all, let's see how the disease manifests in children and adults. This is generally a pediatric disease. About 90% of cases are pediatric. The peak incidence is between 4 and 6 years of age. And among adults, it's generally a middle-aged adult disease. As you can see, the incidence is extremely different between children and adults, and the male to female ratio is about 1.5. To give you a rough figure, I would say that about 50% of patients with IgA vasculitis develop nephritis, and this is what we call IgA vasculitis nephritis. But the clinical manifestations are very variable and also depend on age. Purpura is sort of the sine qua non condition for the development, for the diagnosis as well of IgA vasculitis. Sometimes, especially in adults, it can be the only manifestation of the disease. It's generally more prominent below the waist with sparing of the upper part of the body. Sometimes purpuric lesions may ulcerate, and this occurs particularly in adults. And generally, if you take a biopsy of the purpuric lesions, it's usually a leukocytoclastic vasculitis, which is not which is not helpful in the differential diagnosis. But we will see that if we do immunofluorescence and we look for IgA deposits within the vessels of the skin biopsy, that is very helpful to make a diagnosis of the disease. Arthralgia or arthritis can be present. These are often migratory. It's a non-erosive type of arthritis. It usually involves multiple joints, but it responds quite well to glucocorticoid therapy. Gastrointestinal involvement can be sometimes very severe. There is often a non-specific abdominal pain, but there can also be very severe manifestations, sometimes life-threatening manifestations like bowel ischemia, intussusception, and so on. And finally, nephritis, glomerulonephritis affects about 50% of patients. It is in some cases, it's metachronous to the onset of the disease, but it's generally within 3 months of disease onset. Here we see just a few pictures of how purpura can appear. And in this patient, you can see purpura and arthritis. This is quite evocative of the disease, as is also the finding on CT scan, for instance, of thickening of the bowel wall related to inflammation and ischemia. This is a case of intussusception, which is quite a peculiar gastrointestinal manifestation of the disease. And this is an endoscopic image taken from a colonoscopy of a patient with gastrointestinal involvement. We can see that the purpuric lesions are very similar to what we see on the skin. This is a large series of patients, one of the largest published to date, with adult onset IgA vasculitis. It's 260 patients in France, and this study was coordinated by Alexandra. As you can see, the mean age at diagnosis was 50 years. There is a sort of male predominance. Skin symptoms were universal. It's by definition a skin disease. Joint involvement was quite frequent as well. Gastrointestinal disease was almost in all patients. There was some degree of abdominal pain, but severe manifestations were in about 1/3 of patients. And then other rare manifestations which really differentiate these vasculitis from other small vessel vasculitides are, for instance, peripheral neuropathy, which is extremely rare in patients with IgA vasculitis, or also diffuse alveolar hemorrhage, which is exceptional in this disease. And as you can see, there is a polyclonal increase in IgA levels, but this is in about 50% of patients. If we compare children and adults, the phenotype of the disease is quite similar in terms of the types of organs that are usually involved, but you can see that there is a difference in frequency, especially of kidney involvement, and especially when the disease is fully established. So we have a difference not only in frequency, but we also have a difference in severity of kidney disease. There are no diagnostic criteria for IgA vasculitis, but we do have classification criteria. The most used are the ones developed by the joint initiative by Euler, Printo, and Press, and coordinated by Cesar Ozen, which were developed for children. And these require the presence of purpura plus one or more of the other items that you can see here, like abdominal pain, arthritis or arthralgia, kidney involvement, and histological evidence. These criteria for the classification of the disease, not for the diagnosis, they have a high sensitivity and they have a good specificity, and this is what happens in children. But you can also apply these classification criteria in adults, and there has been a recent work, again, by Cesar and Ozen and her group in Turkey, but also involving other centers in Europe as well, that show that if you use this classification criteria in adults, they perform well, especially if you exclude upfront a diagnosis of ANCA-associated vasculitis and cryoglobulinic vasculitis, which are, of course, well-known mimickers of IgA vasculitis in adults. So the diagnosis generally in children is a clinical diagnosis. In adults, we usually require biopsy because the mimickers of this disease in adults are more frequent and more numerous than in children. It is also very important to rule out secondary forms of the disease when the diagnostic workup. So it should include an evaluation of potential underlying liver disease, inflammatory bowel disease, of the use of drugs, of the presence of malignancies. So this is extremely important, especially in adult patients. A diagnostic test is usually a skin biopsy because we can easily take a skin biopsy. It's, of course, less invasive than a kidney biopsy, and we can detect IgA deposition and complement deposition in the dermal vessels of a skin biopsy. But the problem is that we have to do with a number of limitations of these procedures. We need to take fresh biopsies. We need to have a representative biopsy, and sometimes we cannot, even in these cases, we cannot detect IgA deposition. And this occurred in a French series of patients in about 20% of patients that had a biopsy-proven, a kidney biopsy-proven disease. So the deposits were detectable in the kidney biopsies, but were not detectable in about 1/5 of patients on the skin biopsies. So these limitations have to be taken into account. So the diagnostic workup in adults starts from a clinical diagnosis of the disease. Then the second step is understanding if there is an underlying etiology and also grading the severity of the disease. And this goes through different investigations, which include microbiological tests, autoimmune tests, and biopsies as well. And then we also have to address possible triggers of the disease, which are not necessarily the cause of the disease, but something that contributes to the onset of the disease. And I think Alexandra will touch on this point. This is a scheme that is taken from a large European initiative that Alexandra and I are coordinating on the development of guidelines for the management of patients with adult onset IgA vasculitis. Kidney disease is, as I said, quite frequent. It's about 40 to 60% of children and 50 to 80% of adults. It's again usually quite close to the onset of the skin rash. And there are many, many different manifestations. The range of clinical and laboratory abnormalities in patients with IgA vasculitis that develop kidney disease is quite wide. And we have a proportion of patients just presenting with isolated urinary abnormalities, particularly microhematuria and subnephrotic proteinuria. But microhematuria can also have some episodes of gross hematuria, which are usually intra-infectious, and this is what also happens in IgA nephropathy, so the kidney-limited form of the disease, let's say. But a few patients also develop nephrotic range proteinuria, often without a full-blown nephrotic syndrome. And especially in adults, we can also have a more subtle, more insidious presentations like a chronic kidney disease. Finally, a small proportion of patients, but sometimes, it's a remarkable clinical event. They develop a rapidly progressive glomerulonephritis. Considering the different manifestations of the disease and especially the histology of the patients also depends a lot on what indications we have for a kidney biopsy. So in children, of course, kidney biopsy is less frequently performed. It's usually performed in patients that have a nephrotic range proteinuria or in patients that have a reduced, even a slightly reduced kidney function, so with an estimated GFR less than 90. And also in patients that have a persistent, although not nephrotic proteinuria. This is a view shared by the International Pediatric Nephrology Association and also by the Shared Initiative. Whereas in adults, the role of kidney biopsy is more important, I would say. It's more frequently recommended because it is important for differential diagnosis, and it's also important because it allows the diagnosis more reliably than a skin biopsy, and also because it has a prognostic relevance. Because in the kidney we can appreciate the degree of chronic changes along with the florid inflammatory changes that usually hallmark the disease. And we usually think that IgA vasculitis nephritis is very similar to IgA nephropathy. This is partly true, because in general, the inflammatory aspects of IgA nephropathy are more frequent in patients with IgA vasculitis nephritis. This is the case, for instance, of crescents and endocapillary hypercellularity, which are more common in patients with IgA vasculitis nephritis than in patients with IgA nephropathy. Crescents are usually circumferential. This is a subtle difference, but sometimes it might help. These are circumferential in IgA vasculitis nephritis and segmental, usually in IgA nephropathy. Whereas fibrinoid necrosis, which we would expect in patients with a vasculitis, is not so frequent and it can be seen in about 10% of patients. The MEST C-score is a histological score that we use a lot in IgA nephropathy to grade the different components that are of the kidney that can be affected. So M stands for mesangial, E stands for endocapillary hypercellularity, S for sclerosis, T for tubular involvement, tubular interstitial involvement, and C for crescents. This is a series of patients studied in Germany. You can see that there were patients with IgA vasculitis nephritis and patients with IgA nephropathy, and they were compared. And actually, we can see also from this study that endocapillary hypercellularity was more frequent in patients with IgA vasculitis nephritis than in patients with IgA nephropathy. And this also was true for crescents, especially for C1, so for a not a diffuse or universal presence of crescents. Whereas on the other hand, we can see that sclerotic changes, tubular atrophy, interstitial fibrosis, they were more prominent in patients with IgA nephropathy. So we can say that although the manifestation of the disease histologically in the kidney is quite similar because it's a mesangial proliferative IgA dominant glomerulonephritis, the presence of chronic changes is more prevalent in patients with IgA nephropathy. And this is also intuitive because it's a kidney-limited disease. It's not a full-blown disease, whereas the inflammatory changes are more prevalent in patients with IgA vasculitis nephritis. And these aspects that we capture using the MEST C-score are also prognostically relevant. This is a study that was published a couple of years ago. It's a large cohort of patients with adult onset and pediatric onset IgA vasculitis. As you can see, most of them received some degree of immune suppression, and these analyses were done on the immune suppressed patients. And you can see that their eGFR trajectories could be grouped using an unsupervised analysis, could be grouped into two main profiles. One was the blue one, which is a stable disease that never develops kidney failure. So it starts with a normal eGFR and it persists with a normal eGFR. Whereas another group, which is the red one, has a different profile. The eGFR is slightly reduced at disease onset, then it probably recovers or it goes through a phase of hyperfiltration, and then it declines over time and can develop in the long term chronic kidney disease. And this subgroup was actually the subgroup that had E1, which means endocapillary hypercellularity, which means glomerular inflammation. So probably the message from this study is that even if it's a slight change, the presence of hypercellularity in the intracapillaries is a sign of inflammation that we can treat, we can recover kidney function, but in the long term, this initial kidney injury will be so probably the main cause of the development of chronic kidney disease. In adults, it's clear that what we see also depends on patient's age. So if we consider this study that was done in the UK, the group led by Alan Salama differentiated the presentation of the disease, or looked at the presentation of the disease in different age groups. And you can see that chronic changes were more prevalent in patients with an onset in the late decades, whereas they were less frequent in patients with an age comprised between 18 and 30 years. And likewise, the presence of the development of end-stage kidney disease at disease onset or during the follow-up was much more frequent. I mean, this is intuitive, but we don't know what is the contribution of the disease or comorbidities. The thing is that already at the presentation of the disease, you can see that the eGFR is much, much different between patients in the younger age group and in the older age group. So probably the disease hits already in a different way depending on the age groups. But certainly comorbidities play a role in shaping this presentation and also in shaping the progression of the disease. Prognostic factors can be ethnicity. African American patients usually have a worse outcome, but this is for genetic reasons probably related to that APOL1 genotypes, but also patients with with diabetes or chronic changes on biopsy can have a worse outcome. This study, which was published 1 year ago, focused on proteinuria and looked at proteinuria trajectories and identified 3 groups, as you can see, with an increasing degree of proteinuria, and it clearly showed that both in children and adults, proteinuria matters in terms of long-term outcome and development of chronic kidney disease. And finally, this study, in terms of prognosis, developed a sort of risk score. This was interesting because I think this is one of the studies that really integrated clinical sort of laboratory abnormalities like albumin levels and eGFR and histological abnormalities. And you can see that the score takes into account all of these factors, and the area under the curve of this ROC curve was quite nice. So it is quite a reliable score. The disease is certainly a complex disease, and we don't know much about its pathogenesis. We usually tend to assume that the pathogenesis of IgA vasculitis is very similar to the pathogenesis of IgA nephropathy, which we know better. There is this well-known 4-hit hypothesis where we have plasma cells in the mucosa, like in the gut especially, that produce abnormally glycosylated IgA. These IgA become immunogenic. Their immunogenicity makes allows the formation of immune complexes, which are made of IgA and IgA, or IgG and IgA. These immune complexes tend to deposit within the kidney and predominantly in the mesangium, where they instigate a sort of pro-inflammatory and pro-fibrotic reaction, which leads to chronic kidney damage, or sometimes to acute kidney damage. But I think that these 2 diseases have a different behavior. One is a clear small vessel vasculitis, IgA vasculitis, and the other one is a mesangioproliferative glomerulonephritis. We also saw that they have some histological differences. So the real links in the pathogenesis of these 2 conditions are not well understood. Some genetic factors in IgA vasculitis show that this is clearly an HLA associated disease, so it's a typical autoimmune disease. This is a GWAS, which was it's not been published yet. It's in a biorepository led by the Columbia group of geneticists, in particular by Christoph Kiriluk. And they showed an association with HLA class 2, but they also showed, very interestingly, that the disease is associated with variants in the gene encoding for the receptor for the Fc portion of IgA, so the Fc alpha receptor, and also for an inhibitor of this receptor signaling. So this means that even the genetic predisposition of the disease revolves around the binding between IgA and its receptor. And so IgA probably matters in the pathogenesis of the disease. But this is a vasculitis, so we expect that we have a cellular component as well. So it's not just autoantibodies or antibodies or immune complexes. We also have cells. And a couple of studies demonstrated that there were cytotoxic lymphocytes and NK cells in the lesions, and because the granulolysin and the granzyme B levels were increased in patients with IgA vasculitis nephritis, and they were detectable also in kidney biopsies as compared to healthy controls. Unfortunately, most of these studies did not compare IgA vasculitis nephritis and IgA nephropathy, and the only comparison was between IgA vasculitis nephritis and healthy controls. This study was done by Alexandra and showed that some memory cells, so experienced lymphocytes, are trapped in the lesions, so their levels in the circulation are lower than in patients than in healthy controls, and we can detect these cells in the lesions. So CD4 positive and CD8 positive cells, which express receptors for chemokines like CXCR3, they are in the lesions and participate to the lesion. And then we also have particular cytokine profiles in these patients, which show that IL-6, which is a very, let's say, pleiotropic cytokine with effects on B cells, on T cells, on macrophages, and on fibroblasts as well, is increased in the circulation of these patients, and TNF alpha as well. And so these are important clues also for potential treatments in the future. And finally, we also have a deficiency in regulatory T cells. Regulatory T cells are low in patients with IgA vasculitis as compared to controls in the circulation. And interestingly, when we treat these patients and when these patients enter remission, the levels of Tregs go up. And finally, but not, I mean, very, very relevant to the pathogenesis, I think, and also for the potential treatments is the role complement. We know that in renal biopsy lesions, we usually detect C3, which is probably a sign of the activation of the alternative complement pathway, but it can also be an activation of the whole complement system. And the co-localization of C3 with IgG and IgA makes this disease even more aggressive. This is a recent study that showed by immunofluorescence that if C3 are co-localized with IgA or with IgG, the renal injury is more severe. And this is my last slide to just tell you that the disease is probably a complex one determined by genetic factors and probably lifestyle or different types of predisposition, but we need in most patients, especially in children, we need triggers. And these triggers are usually infections, which are very prevalent, especially in the pediatric population, whereas in adults, probably the triggers are different. They can be drugs, they can be underlying diseases or accompanying diseases, but this is probably something that really instigates the disease onset. And I leave the floor to Alexandra, who will continue to discuss overlapping conditions and the treatment of IgA vasculitis. Thank you.
Okay, thank you so much, Augusto, for this great talk. So it's now my pleasure to introduce our second speaker, Dr. Alexandra Audemard-Verger. She's a professor of internal medicine and clinical immunology at the University of Tours in France, where she also coordinates the Adult Rare Autoimmune and Autoinflammatory Diseases Competence Center. She's a clinician scientist with expertise in systemic vasculitis, including IgA vasculitis, but also in systemic lupus erythematosus and rare autoinflammatory diseases. So thank you very much for joining us, Alexandra. You can go ahead.
Thank you, Tom, for this kind invitation. I'm really happy to be here today. Just share my screen with you. Okay, it's gonna be okay. Yeah, so hi everyone. I'm super delighted to be on stage with Augusto today for this webinar. Over the past 3 years, we have worked extensively on the clinical first position statements for adult IgA vasculitis, and they have now been finalized, and they should be available in the coming weeks. This project has required significant investments of time and efforts, and I would like to sincerely thank the EUVAS and Augusto for their leadership and their dedication on this work process. To start, I would like to share with you one thought. IgA vasculitis is often introduced as a pediatric disease, which is probably one of the first traps it sets for adult physicians. In adult, it's a topic worth paying attention to. It's probably less rare than we think, and we still lack strong evidence-based medicine to guide therapeutic decision. That's why we have settled a few years ago this initiative to help the physician to take the good decision for the patients. These also mean there's a real opportunity and a need to develop well-designed therapeutic trial in the field. Yes, so over lunch, let's us trying to make IgA vasculitis a little less mysterious. So these are my conflict of interest. As I was saying, Augusto, a part of the job of the physician when you have to face a patient with IgA vasculitis is to look for a trigger and to treat it. You also have to look for an underlying condition which can have favorize the vasculitis. So this is a statement that I would like to share with you today of the initiative we conduct. It's a statement 3, and we agree to say that at diagnosis, search for a potential trigger such as vaccine, recently introduced drug, mainly antibiotics, mainly penicillin and doxycycline, or acute infection. For instance, it's frequent, all kind of infection has been described with all of the pathogen, whether viral, bacterial, parasitic, and so on. But they are mainly localized to the mucosa because IgA are in charge of defending the host against the pathogen at the localization of the mucosa. So it's frequently pulmonary or ENT infection or a GI infection. Then you have to look for an underlying disease, and we have demonstrated in the last decade with my group that you have to search, especially with people over 50 years, you have to screen for a solid cancer, mainly pulmonary cancer, urinary tract cancer, as well breast cancer. And the good news is that you will find a localized cancer in the main of the situation. That means IgA vasculitis can be thought as a paraneoplastic condition. So please search for a cancer at the diagnosis and during, let's say, the 2 years after the diagnosis. You also have to search for a monoclonal IgA gammopathy of unknown signification or as a part of multiple myeloma. We have demonstrated with my group several years ago that some patients express a really severe disease with a really refractory disease to a classical treatment such as corticoids, immunosuppressant therapy, and they often harbor a really severe GI phenotype with bleeding. And we have shown that in the skin, when the patient have monoclonal gammopathy, the deposits are not polyclonal, but are monoclonal. So that means that you have to target the monoclonal IgA components. And these patients, a case series of 10 patients, that they all respond to plasma cell targeting therapy. So you have to search whether for mucosal cancer, a monoclonal gammopathy, and also as a liver disease, because the hepatocytes are in charge of clearing the IgA complex. And for instance, in the case of cirrhosis, it can favorize the disease. There's also autoimmune disease which can be associated, such as Crohn's disease and spondyloarthritis, and it's often difficult to to make the distinction with the feature of the vasculitis, because vasculitis could involve the joint and the GI involvement. So it's really important to ask yourself the question of other autoimmune disease associated. I want to share with you now a recent cluster analysis we've done with my group and with the help of the Slovenian group of Dr. Alexandra. So we study the cohorts, the French cohort that Augusto mentioned a few minutes ago, about including 260 French adult patients. And we did unsupervised clustering analysis. And we have found 3 different clusters that are shown in this graph and is in this tendogram as well. It was quite evident that there were 3 clustering. And we could summarize this study as this one. The clusters 2 were mainly men and mainly young men. There harbor mainly GI involvement and joint as well involvements, and there were super inflammatory on the laboratory finding. Usually IgA vasculitis is not like ANCA, for instance, is not a super inflammatory disease, which means that the CRP is not really elevated, except in the case of GI involvement and in the case of cluster 1. The cluster 2, it's about middle-aged patients, and it's quite a non-severe cluster where you can have, of course, cutaneous involvement, but joint involvements. And the cluster 3 was the main severe cluster, and it includes old patients with abnormal kidney function, with a lot of kidney failure. And it could be relied to what Augusto said, that when you're getting old, you have a more severe disease. Of course, the role of comorbidity play a lot, but analyzing the data of the of the kidney biopsy, we have shown that they present more extra capillary proliferation, more fibrosis, and so on. And they also present high IgA level. What is interesting is that we were able to correlate the baseline cluster to the outcome. For instance, I would share some finding with you. Cluster 1 and cluster 2 experience much more relapse than the cluster 3. So that means that you have to follow these patients more carefully, and you have to check for therapeutical compliance. Cluster 3, when you follow the kidney function, had a dramatic higher chronic kidney disease. For instance, 80% versus less than 1/3. And when you look to the biopsy, they show more tubular interstitial damage, fibrosis, and extracapillary proliferation. We were able to validate these results in independent Slovenian cohorts. So that means that this study could have important clinical implication. And we advise in this paper that for cluster 1 to carefully monitor for GI complication, because at the diagnosis, the patient, they constantly present purpura, and the GI involvement could be a bit delayed, for instance, 1 week. So you have to educate your patient saying, okay, if you have an abdominal pain, call me back, please. It's really important. And And also, at their presence, lots of relapse, you have to ensure treatment compliance. So cluster 1 are mainly followed by rheumatologic physician. As the same as cluster 2, whether that's cluster 3 should be follow up with nephrologists, and you have to carefully monitor the proteinuria rates and to start nephroprotections treatment. And as Augusto say, proteinuria is the main laboratory finding that drive to CKD, so it's really important. You also have to assess, like in every patient with CKD, the cardiovascular risk, and to treat the cardiovascular and to prevent it. It could be also a good thought to have a geriatric support and follow-up. Regarding the kidney prognosis, Augusto talked a lot with you about the kidney prognosis. But I want to share with you this data. This study, who was published by Evangeline Pilbou, a French nephrologist, about 2 decades ago, that showing, just to emphasize that it's really a matter of concern, the kidney involvement. So really, please, at diagnosis, search for a kidney involvement during lipstick and follow up the proteinuria rates. So in this study, 250 adult IgA vasculitis patients with IgA nephropathy were included with the more huge follow-up of 15 years. And you can see that only 1/3 of the patient did not present kidney CKD. That means they only present remaining hematuria and proteinuria. 14% of the patient present moderate kidney impairments, 13 severe kidney impairments, and 11% end-stage kidney disease. Only 20% of the patients were in complete remission on the renal points. That means that they have no proteinuria and no hematuria. So it's to emphasize as well that we definitely need more efficient treatment to avoid CKD. Regarding the prognosis, we were asking if the gender could be an overreaching prognosis in adults. Studying the French cohorts, we study 164 male data comparing to 85 female, and we compare baseline clinical biologic data, histologic data, and response to therapy. And to make a long story short, we had observed in this study published a couple years ago that at baseline there were no main difference regarding the joint, cutaneous, and GI involvements, but they present a more severe renal disease with higher level of IgA in the sera, higher creatinine, and higher rate of proteinuria in males. And what was a bit surprising, it was that the male did not respond as well as the woman to the treatment. They were given more prednisolone pills, more cyclophosphamide, more immunosuppressants treatments such as azathioprine, but there were less responder. So we emphasize that gender could be a new prognosis factor in adults. That means that when you follow a patient, a male patient, you have to be more carefully and to follow up more closely, and probably to be, in certain cases, for instance, in the case of renal involvement, more aggressive with the treatments. So let's move now to the to the chapter of the treatments. So just to remind you, there is no evidence-based medicine. What I will share with you, it's only about experience that we share in the group, but it's a start. So I propose this strategic approach. As I was saying, there's only one RCT available in the literature so far, and it was conducted by Evangeline Pilbu a decade ago, and she demonstrated that the addition of cyclophosphamide in addition to glucocorticosteroid in severe form, both renal and GI form, was not efficient. So the debate of should we give cyclophosphamide to the patient is not closed, and the only data is more like to not give. So there's a lot of unsolved question, but we can summarize a strategic approach with this picture. So you have to treat the trigger, for instance, in infection. So if the patient presents with infective endocarditis, you have to treat whether or not the patient will not get into remission. You also have to treat the underlying disease. And I show you that if you highlight cancer or monoclonal gammopathy, you have to treat them, and the disease, the vasculitis, will recover with the treatment of the cancer and the monoclonal gammopathy. Regarding the treatment of the vasculitis, the strategic approach is based on involved organs and disease severity. So it goes from to treat the patient with symptomatic treatments, such as analgesic for pain of the joint, to ACE inhibitor in case of proteinuria, and you have to avoid non-steroidal anti-inflammatory drugs because the patient, they could have a renal disease or a GI disease. Regarding the immunomodulatory treatment, I will go back afterwards, but one of the treatment which is in the daily practice quite efficient is colchicine. Of course, treatments which is almost every time efficient, it's corticosteroid, but you have to give the patients a lot of months and a lot of dose of corticosteroid. And as you know, there's a lot of side effects. And regarding immunosuppressants or biologic, there are less evidence-based medicine as well. So we discussed for months, and we agree with the European IgA study group on these statements. So it's regarding skin lesion, if the most of the patient, they only have one flare, about 80%. So you don't need to give a specific treatment for this kind of lesion because they will recover spontaneously in 2 weeks. In the 20% case of the patient that will relapse frequently, and it's a matter of decreased quality of life because, of course, when you live with purpura in all time in your lower limb, you could be affected by this condition. So the two treatments are colchicine or dapsone. So you may consider with the patient. Colchicine could be maybe given first because it has less side effect than dapsone, and you have to go for a long treatment. It's a treatment that should be given for 6 months, for instance. In the case of limited IgA vasculitis, in the first flare, when you have a really severe flare of the cutaneous pattern, with, for instance, hemorrhagic bolus or necrotic purpura, you can give the patient a short-term glucocorticosteroid. For instance, let's say from 10 to 20 milligrams for 1 or 2 weeks, but not a long-term treatment with corticoid. In case of mild GI in form, so we agreed to define the mild GI form, which with isolated abdominal pain with a normal ultrasound or CT scan. In the adult, we are more likely to use a CT scan. You could go for symptomatic treatments such as light diets and a close monitoring, but you have to be really careful, and the patient which are not treated with corticosteroids should be really mild form. In all other form, moderate to severe, you have to give the patient glucocorticoid pulse and oral glucocorticoid. And it's generally super fast, the recovery of the patients. It's mainly the day after the pulse, he recover, no abdominal pain. So it's really efficient. And I do believe that the pulse are more efficient. And you have to introduce, you have to stop, of course, food, and you have to go with a, let's say, parental nutrition. And it's a part of the treatment to make the GI resting. Salvage treatments with plasma exchange or cyclophosphamide should be considered for the really rare refractory GI involvement, and in daily practice it's quite rare. It's maybe one patient for let's say 100, and cyclophosphamide take a while to act, so maybe discuss plasma exchange for really severe GI involvement with a lot of bleeding, a lot of ischemia, necrosis in the bowel could be discussed, pounding and weighting, the benefits, the pro and the cons. Regarding the kidney disease, which is a matter of importance, we had agreed that patients with poor prognosis factors such as kidney function impairment linked to the vasculitis, not of course linked to the comorbidities. That's why you need a biopsy. In the patient with a nephrotic range of proteinuria or persistent proteinuria, and you will see that the cutoff is quite low. So we agreed to say that persistent proteinuria over that 0.5 gram per gram on a short course of renin, angiotensin, aldosterone blockers, or crescentic or rapidly progressive glomerulonephritis. In this case, glucocorticoid should be prescribed. The duration range generally from 6 to 9 months, depending on the response of the patient, and the dose you can, in severe case, you can of course go for methylprednisolone pulses, and the start dose rank from, let's say, 1 milligram kilo to 0.5 milligram kilo. But it's only about practice, and it's not evidence-based data that I am sharing with you. In the same case of GI involvements, the addition of plasma exchange and endoxan and cyclophosphamide could be discussed in some case. So these are our take-home message with Augusto. So it's a really it's a disease of interest where there are a lot of things to do, especially regarding the treatment. So we will kindly remind you that you have to always look for organ, trigger, and hidden underlying disease. You have to treat the cause, the trigger, the underlying disease. Remission may follow sometimes. So it's one disease, but multi-phenotype with different outcome. Strategy beats protocol, so you have to personalize the treatment regarding the severity and the organ involved. And after decades, adult IgA vasculitis will finally have its own first recommendation released in the coming weeks. And so I'm happy to say that and I really do believe it, that for adult IgA vasculitis, the era of extrapolation is moving to any. Thank you for your attention.
Thank you, Alexandra and Augusto, for the great talks. Very interesting. We have 5 minutes for discussion and we have a few questions in the chat. So first question is for Augusto. Someone is asking whether IgA deposits alone are enough for diagnosis or whether hyperplasia in the mesangium or inflammatory findings, urinary sediment are needed for the diagnosis of IgA vasculitis at the kidney level.
Well, this is a good question because there is some degree of IgA deposition even in healthy subjects in the mesangium. So this can be found in about 5 to 10% of healthy subjects. So it's not a specific finding. This needs to be detected in a compatible histology. So this means that we need to have mesangial proliferation and a capillary or a hypercellularity or other changes. And sometimes something which I didn't mention in the presentation is that also IgA deposition on the capillary walls, especially subendothelial deposition, can be found a little bit more frequently in patients with IgA vasculitis nephritis than in patients with IgA nephropathy. So this can also be a sign of the disease.
Thank you. And this doctor also asks whether low complement, low C3, means infection-related IgA or
I
severe
think
disease.
this is not unfortunately this is not a reliable marker to say that this is an infection-related IgA process. Neither IgA vasculitis nor IgA nephropathy.
Thank you. Now a question for Alexandra. Do you have experience with IV immunoglobulins for severe skin involvement? And I would add another question to that myself. Do you have experience with rituximab in severe patients?
Yeah, good question. No, I didn't have any experience of IgAV. There's a case report in the literature, but it's really hard to draw some conclusion. And for rituximab, Augusto and the European group published a few years ago a case series of refractory or patients that were corticosteroid dependent, but there were no control group. But it could be a good drug. And the truth is that in France we conduct a trial, a randomized control trial. We just had last month giving rituximab to severe renal forms. So we will have the results in, let's say, 1 year, but it could have to be mentioned that in IgA nephropathy, isolated one, it's not really efficient. We have more data, and it's linked because the rituximab did not decrease probably the rates of the IgA in the sera. Okay, it only seems to work with IgG, sorry.
Thank you. And I think we have 1 minute to one last question from Ono Tang asking whether cluster 3 of IgAV looks to resemble IgA nephropathy with predominant renal involvement in older age, and what would be the clinical characteristics to distinguish between the two, I think, besides purpura, of course.
Yeah, it's a good thought. Yeah, it's only the story that the patient in cluster 3 used to have a past medical history of purpura. But I really do believe that some patient with isolated primary IgA nephropathy are patients who used to have an IgA vasculitis that could have been non-diagnosis. So So yeah, we could think that IgA nephropathy is a chronic stage of certain form of IgA vasculitis, but it's not true, of course.
Thank you. I think we can close now. Thank you so much for your very nice talks. And I think Thomas wants to remind of the next webinar next week. Thank you so much.
Bye-bye.
Bye.
Thank you to all of you.
Yeah, thank you for your great presentation. So we hope you will all also be able to join us all next week, Tuesday, for the next webinar, ERN-RITA. It will keep the spirit of the Vasculitis Awareness Month alive because it will focus on personalizing immunosuppression and care pathways in ANCA vasculitis. So we hope to see you all there.
Thank you. Have a nice day. Thank you. Bye-bye.